Well, thanks for joining, folks. This is a change to the schedule. In fact, I'll admit I can't remember what was originally scheduled for today, but we have, there's been some telehealth questions coming up in our last few rounds of hubs and spokes meetings. We've heard some concerns about, upcoming potential legislation changes to this. And so, for all those reasons, and then also I think there's still some misconceptions about telehealth, we thought it would be a good time to revisit this topic. So that's why we made those changes for today. So here are our objectives today. Sometimes I'm going to be referring to all telehealth services, but mostly my focus is going to be on teletherapy specifically. So just kind of giving that heads up ahead of time. So I'm going to give some very brief historical context on teletherapy and the evidence for and against this way of delivering treatment. We'll talk about the successes and the challenges in providing teletherapy for substance use disorder, and then we'll review specific strategies on what we can do to kind of make the facilitation of that a bit of a smoother process. And then we're also going to talk about, I'm going to highlight just a little bit of the past and upcoming legislation related to being able to provide telehealth services in West Virginia. In terms of a proper disclosure, I want to thank Laura Lander. The vast majority of these teletherapy slides are hers that she lent to me. She was unable to present today. And then I also want to thank Dr. Law for sharing her slides on current and pending rulings regarding telehealth. So those are my two official disclosure / shout outs. So let's look at the data section of today's talk first. So teletherapy began as a potential option for treatment back in the 1960s with the start of telephone hotlines. Online therapy chat forums then came onto the scene in the 90s. And 1995 saw the first official online therapy service, which was called cyber counseling. I forgot when we used the term cyber all the time. A lot of people are probably familiar with the therapy platform Talkspace. I think that was really sort of the biggest one that changed things, and that came onto the scene in 2012. And then as of today, there are countless online therapy programs and platforms, some which you may recommend in that list. I feel like if anybody listens to podcasts every day, these days, I feel like Talkspace or BetterHelp are the ones that seem to be the most kind of advertised in any podcast I listen to. And so my guess is you all can guess what is responsible for the sudden increase in a significant amount of online platforms that became suddenly available. And we're probably all guessing the same thing. It was really the pandemic. The pandemic changed the face of that. And we're going to see this pandemic effect kind of take shape on the next slide as well. Just as an aside, something I won't be going over today, but for example, some of these online programs that are listed here, some of them accept insurance and some don't. Okay, here's some more numbers coming your way. So it is likely no surprise to you that after 2020, you see a dramatic rise in the growth of the telehealth industry because of that pandemic effect I just mentioned. So the global telehealth market was estimated at $123 billion in 2024, and it is projected to expand at a compound annual growth rate of 24% from 2025 to 2030, where it's then projected to reach $455 billion, which is an enormous amount of money. The U.S. telehealth market, so us specifically, accounted for the largest market share in North America in 2024. And so I share that as a reminder to you that telehealth's not going anywhere, and it is definitely in large demand. Here's a brief timeline that highlights just some of the research out there that supports providing teletherapy. I appreciate that this slide is really the research listed on there is pretty small. This is also in the references section, but hard to read. I just want to highlight one of these. So the 2017 study listed on here. So that group looked at 13 studies that included almost 4,000 patients. And what they found is that the patients that were treated via telemedicine were more likely to be retained in therapy than patients treated in person. Telemedicine patients demonstrated a retention rate of 50% at 1 year, whereas in-person patients were retained at a rate of 39%. So for us in the SUD treatment field, that's really important to pay attention to, right? Because one of the common issues that pops up in any meeting that when we talk about retention and engagement in treatment, it's how do we keep them in treatment? How do we keep them coming back to see us? Oh, I lost my mouse. Here we go. So there's several publications out there that have given recommendations for teleservices, but I'll just specifically highlight this one. So SAMHSA released this guide in 2021 to fulfill the charge of the 21st Century Cures Act, to disseminate information on evidence-based practices and service delivery models to prevent substance misuse, and to also help people with substance use disorders, serious mental illness, and then serious emotional disturbances. I think I also have an additional link for this at the end of this in the references section. But high points in the guide include discussion of the data around medication-assisted treatment, and then counseling and behavioral therapies via the virtual modalities that a lot of us are using today. So what the overall data tells us is that there are a lot of benefits to teletherapy, and especially for the underserved populations that we frequently are talking about in this ECHO platform. Really gives us an area of where we can expand. And so let's talk about some of those points of where the benefits are. So it increases access to treatment, especially to those with a lower socioeconomic standing in communities of color and rural communities that experience healthcare disparities. It reduces barriers to treatment, such as transportation, long travel times, childcare. Today is actually a great example. Right in West Virginia, there were areas of West Virginia where the weather was great, and there were areas that the roads were terrible. And folks would have had to be traveling today if they had an appointment. Telehealth can reduce no-show and cancellation rates, can be conducted safely and ethically for most, but we'll talk about some contraindications for that in a little bit. A lot of our patients prefer teleservices. And then what we have found is it's a bit of a selling point for staff recruitment and retention. Offering teleservices now gives staff the option of, being able to work from home or being able to work elsewhere and not come into the office 5 days a week. And when we think about, I'm going to bring it back to ethics. When we think about our ethical principles, what do you notice is being met when we think about the benefits of teletherapy? So we're meeting that autonomy principle by giving patients the right to choose their form of therapy. And we're also meeting that justice principle by making therapy available to all, not just the patients that can afford transportation or that can afford to take time away from school or childcare or their job. So we'll now review how teletherapy is facilitated, and we'll discuss the strengths and the challenges in those applications. While I take a watering hole break, please excuse me. Okay, so let's talk about some of the benefits specific to providing just individual therapy. We'll talk about group in a little bit. This list is definitely not exhaustive, by the way, so please add anything in the chat box here that you also experience as a benefit when you're providing individual therapy. So one we've already mentioned is that it's an easier access to care. For some, they will experience their clients at being more at ease. They may have more walls down because they are in the safety of their own environment, the environment they chose to be in for their individual therapy session. And for some folks, the computer acts as a little bit of a filter for them to feel a little safer to open up in session. We also get a chance to potentially see their behaviors in action, while they're home, dropping, family members kind of stopping by and dropping into the session. Actually, I've gotten some great on-the-fly family sessions out of that, particularly when we're discussing conflict or trying to engage in conflict resolution. I'm able to see that firsthand, as opposed to trying to schedule the family to attend their session in my office. The other parts that's nice is that we're able to, share visual images, videos, online resources in the moment. For a lot of us, we have them, at a mere click away on our computer, and so that's really helpful. And then also we get to see their home environment. So I've had the the experience where I'm working with a patient and they have kind of never really mentioned their home environment or issues in their home environment. And then when we had a televisit, I was able to see their background, and it is not the home I expected. And it's clear that there are some safety concerns for them at home. And so being able to see that firsthand was really helpful. Let me make sure I'm not, let me go backwards. Let me make sure I'm not missing anything in the chat box, but I don't think I see anything. Okay. So those are benefits, but we also got to talk about some of those challenges. So there's some aspects of individual therapy that do not transfer well to the virtual world. Once again, this list is not exhaustive, so please feel free to add anything that you think should be on here. So when we're doing virtual individual therapy, that does eliminate the potential for physical closeness and ethical touch, particularly for somebody who is expressing grief or expressing certain trauma feelings. Sometimes there's a benefit of us being able to be there right beside them to put a gentle, supportive hand on their shoulder, and we don't get to do that. The other thing that we don't get to do is kind of witness what their physical symptoms are during that session, right? Sometimes there's a lot that we can get from a patient when we're seeing that they're not able to keep their feet still, or they're not able to hold still in their chair, or they've got anxious tendencies happening with their hands. There's just some things that we may potentially miss on a virtual session. Poor internet service for any of you on here who have been engaged in this beautiful individual therapy session. Great work is happening. They're getting ready to open up and or process something difficult, and then somebody's internet just craps out. It's either yours or theirs or both, and it can feel so frustrating. It always seems to happen at the least opportune time. Some behaviors can be harder to redirect. So if folks struggle with having a hard time staying on camera, or also if they're engaging in destructive acts to themselves or others, there could be a way that we could intervene if they were in our office versus harder to do when we're online. When we have safety concerns for them, if there's concern about suicidal or homicidal ideation that has become plans and intents, we've got less options when they are not in our office, and we have to get a little creative, which we'll talk a little later about how to get them the support they need. For patients that are living in spaces that are not safe for them, for example, if there's other people in their household that are not safe for them to speak freely around, that creates some difficult challenges, right? So they may be engaging in they've signed on to your individual therapy, but they're giving you very little, and it's not because they're not wanting to open up to you or not trusting you or wanting to lie, but it's because they just don't feel safe based on who could be listening in the other room. And then again, for patients experiencing psychotic symptoms, paranoid symptoms, sometimes a little harder to assess over video. Not impossible, but just sometimes more challenging.
We had some comments in the chat, and
great.
The person was, the statistics on retention is very interesting. Thanks for sharing. And then clients can do their therapy in a non-public private place at work, which allows them to not have to take a day off work. Also a pro, if they're late, the visit may still be salvageable if all they have to do is hop on their phone instead of driving to the office.
Oh, these are great points. So Dr. Miller, fantastic point. And sort of going back to the justice issue, right? Like I have a job where I'm able to take a whole day off for an appointment if I need to. For a lot of our folks, they aren't working in scenarios where they can do that. So being able to maybe use their lunch hour to engage in a session as opposed to a whole day, huge difference. So I love that you pointed that out. And Lacey, great point too. I've been able to call patients, I have a patient who's 10, 15 minutes late and they are never late. And that tells me, either something's happened or they've forgotten about it. When I call them, I can quickly get them onto the visit as opposed to, there's no way they're going to be able to drive here in time. So that is such a good point. And Carolyn, thanks for that comment on the statistics. Okay, I want to make this chat box. Okay. Group therapy. So, again, we'll talk about group therapy benefits and challenges. So I will admit, when we transferred our in-person COPE program to Tele, which was back in April 2020, which I think I blocked that out, I was one of the therapists that was least happy about that transition. I'm a creature of habit, which means that I don't do well with change. And I just like being in the same physical space for my patients. So I really fought that tooth and nail. If anybody was on here that worked with me back then, I was very much like, we're just going to do this for 2-3 months. We'll be back to in person. I have since come to really not only appreciate a lot of the benefits of having our groups in line, I have actually to the place now where I prefer it this way. It gives us an opportunity to be able to share visual resources in a much more efficient way. I just have everything I need at my fingertips now, as opposed to only having what I brought with me to the physical group room. For patients that don't want to attend treatment within their own small town due to privacy concerns, which happens to in a lot of our rural areas in the state, telemedicine now, it lets them get to participate in treatment in another part of their state, but from the safety of their own home. For patients that struggle with social anxiety, here's an area I've really seen it help with. So participating in a group space from the comfort of their own home, having this screen that's protecting them a little bit from the sort of empathic space of that group room can actually feel less scary. And then for patients that have co-occurring diagnoses, that virtual room can, again, also sometimes be a little bit more of a comfortable space for patients. And then sometimes what happens is we have disruptive patients in group. Doesn't happen all the time, but it happens on occasion. The virtual space has actually helped with that. Sometimes what I can do is mute them or I can remove them, as opposed to there being a potential of a physical conflict in a group that could be really triggering for other folks that maybe have a history of trauma. Again, along with pearls, there are going to be challenges. So there are challenges to this style of treatment. So for example, here are group rules I now repeat at the start of, I run our orientation group here. So for everybody coming into COAT, we have them attend at least one orientation group, if not a few, so they can learn about telehealth, policies and procedures, etc. So here are the rules I now have to go over that I used to not have to. I need to remind them to wear pants. They may plan on just holding their phone chest high and just me seeing their shoulder and head, but inevitably people drop their phone and we can tell when they're not wearing pants. So that's a group rule we have to go over now. I have to remind people that while they can't smoke on camera, but then what they also can't do is duck off camera and smoke and come back on and duck off camera and come back on. That's my favorite. I also have to remind people to please not take your phone with you to the restroom. You may think that you are muted and your camera is off, but my gosh, people forget to do those two things all the time. So there are challenges that we don't run into when we are an in-person group. Other elements that can be challenging, again, some of these are similar to individual therapy, so it eliminates that physical closeness. Sometimes there's an inappropriate video presentation, so the way that folks have their, what they have in their background could potentially be triggering for other folks in the group. When patients disappear from group, that causes some concern because then we can't verify to make sure there's other people not there. Failures of technology, very similarly, there could be the majority of the patients, everybody's internet and audio and visual is working great. One patient's can be a mess and can potentially throw off a group. There's a lack of privacy that we always have to take into consideration. Our patients are committing to us and their group members that when they're signing into group, there's nobody else in there, but we can't 100% verify that. There's a potential for distractions, it can be difficult assessing engagement. And then, so Dr. Miller pointed out beautifully earlier that sometimes what folks can do is join from a public place. That can be easier for them, but not always best for group if that public space isn't private. Lost my mouse again. I'm not doing good with that today. Okay, so just a summary of the pros and cons. So pros are it has been shown to us to be as effective as in-person therapy for most treatment interventions. Retention rates are equal to, if not better. It reduces costs both for the patient in terms of traveling to us and then also potentially for us in terms of office overhead. And that it increases access for clients. Cons are there's a potential for difficulty establishing therapeutic alliance. There's a lack of physical closeness. It limits nonverbal cues a little bit. There can be privacy concerns, internet issues, state licensing and insurance issues, and then concerns about safety interventions. Let's talk about specific strategies now that we can use to reduce some of those challenges that we just discussed. So I told you the pants thing comes up more than once. So let's look at this checklist. So this checklist is specifically for us as providers. We want to be following this when we provide teletherapy. So we want to make sure that we have a HIPAA approved, HIPAA compliant platform. Want to make sure that our internet is adequate, which is not a given in West Virginia, right? Even in some of our more popular places in the state, internet on a good day isn't great, much less on a stormy day. Want to make sure you have appropriate device, that you have a password protected, secure internet, and that you have antivirus software installed on whatever you're using for your services. You want to have a good office setup, so you want to make sure that you have a clear and professional background. There's nothing in your background that you don't want to explain to your patients because they will likely comment on it at some point. You want to make sure that you have a well-lit, good camera position. There's minimized distractions as much as possible. For anybody in here that works from home and has a dog or a cat at home, you know that that is easier said than done. And then sort of a no questions asked, this one's most important, is that we have to have 100% confidentiality at all times. It's also really important that we're communicating confidence in teletherapy, right? And I'll tell you, this is an ethical code I broke when we first went to Zoom for COAT. I remember complaining to patients about how frustrating the process was. That wasn't helpful for them to hear at all. In fact, my patients were more patient with it than I was. They were like, it's cool, Katie, we'll figure it out. It's no big deal. That was not appropriate. I needed to communicate, and I now communicate like, listen, this is going to be a great system. If there's any hiccups, don't worry, we will work through those hiccups.
Hey, Katie.
Yeah, oh,
Question
sorry.
is, what about UDS? Do you do counts?
Great. I'm sorry. I'm trying to pull up the chat box and it won't let me.
No, you are completely fine.
Can you repeat that question again?
It said, what about UDS? Do you do counts?
Oh, great question. Yes. So for drug screens for our program, we do bring folks in person for those. Many moons ago, we were doing the oral swab kits. For a handful of different reasons, we stopped doing that. And so while we have virtual services take place for the medical care, we still have folks come in person for drug screens and come in person for medication counts. Great question. We also want to plan for problems, and I will have a separate slide on that in a minute. So that was our checklist as providers. Let's look at the checklist that we want our patients to be able to commit to in order for us to say, yep, we think teletherapy is going to be a good fit for you. So we want to remind them that they need to be in a secure location. We want to remind them that they need to be located in the state that you're licensed in. So for example, one of our blanket coat rules is that you need to be located in the state of West Virginia and tell us that you're located in the state of West Virginia when you sign in for your visits. And we want to make sure that they're in a secure location, it's in a state, also in a safe location so that they're not driving, that there's not some potential safety hazard around them that's going to cause them any issues if they're then kind of concentrating on our individual therapy session. Also want to make sure that they have the right technology. And so walking them through what's a device that's going to be helpful in supporting the platform that you're using, what's adequate internet that they have, encouraging them to utilize internet safety measures, something like password protection and antivirus software. Also want to make sure that they are in environments where they can talk freely. So both confidentiality for group therapy and then also both confidentiality for themselves. So they're going to be able to get out of individual therapy what they need and want to get out of there. Same thing as us, asking them to be in a well-lit area, good camera position, minimize distractions, and then help them plan for the problems. Keep going to the chat box and it keeps going away and it's dry. Oh, great. Here we go. With UDSs, oh, Dr. Miller said with UDSs, I have some really good luck with UDS sharing from drug court or probation officers so they don't have to come in person to two places. Great suggestion, Dr. Miller. Yeah, that's really nice. If they're already having to travel somewhere for it, well, can we use that too? We have learned that what can be really helpful is orienting the patient to teletherapy ahead of time, especially if that's their first time ever doing it. So just validating for them that it's a different experience, not necessarily a bad experience, and they may find it to be a better experience. It's just a different experience. We want to contact them in advance and encourage them to try to kind of trial signing up or logging in for their session ahead of time so they're not kind of panicked and signing on 2 minutes before your appointment with them. We do want to obtain consent to conduct teletherapy on the platform that you're using. Want to make sure to verify, again, their location and that they're in a private and safe space. We have on occasion asked folks to do a room scan. So if this was a group therapy session and I see Travis down there and Travis Cottrell causing trouble in the corner and I see him talking to somebody, I can say, hey, Travis, can you do me a favor? I'd like to do a room sweep with your camera. And he would sort of take his camera and do a room sweep and to let him know, that's just ensuring your other group members that you're keeping their information confidential because it sort of seemed like you were talking to somebody. Want to review the corresponding rules for individual therapy and rules for group therapy. Plan for technical disruptions. So make sure you get a phone number for your patients. For us, we have the benefit of the system that we use is in our medical chart system. And so I've got their phone number sort of right there in case I need to call them in case there's been some disconnection issue. You want to think about a crisis intervention plan for you in general. Trying to think of how many slides down. We'll talk sort of specific about what's your role in planning for a crisis ahead of time with an individual session and group session. And then again, just reminding the patients, if they've not done teletherapy before, they're not thinking about their background. They're not thinking about what other members in the group are going to be seeing and how that's going to play into their role in here. I think it was a couple of echoes ago when I talked about ethics, I gave the example of, when a patient has something in their background that could be deemed offensive by other group members, like a Confederate flag, what do you do with that? So again, sometimes it's one of those things, they're just not even thinking about it until we bring it up to them in a non-judgmental, but hey, I just want to educate you for the future situation. So let's think about those list of folks that providing teletherapy on a regular basis is not going to be a good idea. So poor internet connectivity, for those of us that do I'm sure you've had the experience of you have patients who 99% of the time their internet's great. It's a super stormy day in West Virginia and their internet's not working well. Well, that's not going to be a reason we want to automatically discontinue teleservices in the future. We just want to keep an eye on it. But for patients that you're routinely having to talk with them about, hey, you're lagging, there seems to be a delay, you're freezing up, hey, can you go to a different room? For those folks, it can be good to make the decision of, I think you need to come in person for future visits. Also, clients who prefer in-person visits, back to that autonomy rule, we want them to have the opportunity. Would they rather come in the building or sign in from video? For clients who can't control the privacy of the environment or the safety of the environment, we want to make sure that they're coming in person. If you're finding that it's maybe harder to develop rapport with that patient or maintain engagement either in an individual or group therapy session, that would be a reason to bring them in future. And then also if you're having a hard time for you, if you feel like the patient is maybe increasing some of their symptoms, something like delusions, paranoia, and you feel like the sort of tele-setup is increasing those, another reason to bring them in person. And then clients who do not respect the confidentiality of others, to me, that's a black and white, 100% absolutely needs to come in person. So let's plan for possible problems. So things to think about with your agency and or your supervisor is how will you handle when a patient no-shows or cancels? Is there a certain amount of no-shows or cancellations where you want to either require the patient to come in person, or if the patient had been coming in person, do you want to require their future visits to be telehealth? Being clear with them about having a camera on at all times. Just identifying if that's a requirement in your agency. Reviewing rules about recording sessions is important. And then crisis intervention plan. It's really good to have to figure out what's your setup where you provide telehealth. Is it from your office where you have other coworkers around? Is it at home by yourself? How are you going to tap in other people if you need help? If you have a patient who is having a medical crisis, if you have a patient who has a suicidal plan or intent, homicidal plan or intent, how are you going to tap in other people? So for me, a number one rule is that I will do not engage in teletherapy on my cell phone. I'm going to use my computer. I'm going to use my laptop. I'll use an iPad if there's computer issues, but I always want to have this handy so that, like Travis, you're just going to keep being my fake patient all day. So if I'm in a session with Travis and I'm concerned about his safety, what I can do is engage in this conversation with him while underneath my table, I'm desperately texting one of my coworkers of, hey, I'm really worried about Travis. Can you look in my chart? He's my 2 o'clock patient. Can you please send 911 over to his house? I can use this as a backup to get some additional help this way. If I'm engaging in teletherapy on my phone, I'm out of options to be able to bring in help. So kind of always make sure you have that backup plan. Please hold while I take another water break. By the way, you guys can tell these aren't my slides. Do you know, who knows how you can tell?
There are no animal pictures.
There are no farm animals. I was broken heart when I finished. I did clean it up myself, but I just realized I didn't put any farm animals in here. I'm gonna have to like owe them an apology when I go home. Okay, I'm gonna wrap up by talking about past, present, and future potential rules related to telehealth. Again, thank you to Dr. Law who gave me these. This is you all on here are welcome to correct me with any of my language, or if there's any of this that I have out of order here. So here are some of the highlights of the rulings related to medications for opioid use disorder. I think most folks on here are familiar with, but we'll go over them anyways. So buprenorphine can now be prescribed via telehealth, and follow-up visits can be conducted via telehealth for now, which we'll talk a little bit more about on the next slide. There is no longer a federal X waiver required for providers to be able to prescribe buprenorphine, and then also, providers are still required to have a DEA registration and complete 8 hours of substance use disorder training. And then what's different with methadone is that methadone cannot be prescribed via telehealth and has to be dispensed via an opioid treatment programs or OTP. West Virginia has had a moratorium on new OTPs, I think since 2016. Anybody please correct me on that. And this regulation makes West Virginia one of the most restrictive states in the country regarding the opening of new opioid treatment facilities. There were a lot of things that changed during the pandemic. Some of those changes stuck, some reverted back to kind of pre-pandemic rules, and then some are still up in the air. So currently there is a requirement to use HIPAA-approved platforms to conduct your telehealth services. So for example, something like using FaceTime on your iPhone would not be allowed for teleservices. There was a very brief period of time where it was just like however you could reach patients, if it was on your phone call, you know, if it was just any different way you could do it, but now it is reverted back to they have to be HIPAA compliant. I hope I say this name right. The Ryan Haidt Online Pharmacy Consumer Protection Act of 2008 is how the DEA regulates online prescribing of controlled substances. It generally requires an in-person medical evaluation before prescribing controlled substances via telemedicine. However, during the pandemic, that requirement was waived, which allowed tele-based MOUD prescribing without in-person visits. So this waiver is lasting until the end of December of this year of 2025. So once this expires, there's going to be questions as to whether a person could receive controlled medication without having an in-person visit with their provider first. The DEA has been tasked with creating a special telemedicine registry for providers that is hopefully going to help them distinguish those who are legit virtual providers from just some of those online scam pharmacies. But to my understanding, and again, please correct me if you have different information, I think this process has been delayed because of the government shutdown. And then here are those rules proposed by the DEA. They were proposed back in 2023. So the 30-day telemedicine prescribing rule allows prescribing of schedule, excuse me, 3 and 4 controlling substances, including buprenorphine, for up to 30 days via telemedicine without an in-person visit. And then to continue treatment past 30 days, an in-person eval is required. However, again, this has been extended to December 31st of the year. And I don't know what the general expectation is of what will happen at that point. I think people in the field are very hopeful that it will lean in the favor of being able to continue the way we're doing things, but that's not a promise. We already have somewhat of an update to the Medicare waiver, which just expired on September 30th. So this was the waiver that allowed much of telehealth care to occur in places that hadn't been previously allowed. Post expiration, folks have been anxious about what this means for whatever their, what services are going to have to be received in person and whether they can still use virtual at all. The good news is, or the good thing is that they really have recognized the need to maintain services for those being treated for substance use disorder or a co-occurring mental health condition. So this means those patients can continue to be seen in home without having to meet the geographic requirements that others will need to meet in order to get telehealth services. There will likely be additional guidance and potentially even extension of these waivers once the government is back up and running. I actually have that written in a more passive aggressive way in my notes, but I'll just say once they return to working. Just leave it there. I don't see anybody in the chat box correcting me, so I'm going to take that as a good sign. So audience participation time. Feel free to unmute yourself or to add in the chat box. I'll just sort of throw out these questions all at once. So for those of you that do facilitate telehealth services, what do you find helpful about it and what do you find challenging about it? And then for those of you that don't facilitate telehealth services, what's your sense of what's holding you or your agency back from that? And what are your perceptions of telehealth visits as a health service? And again, feel free to unmute yourself or drop in the chat box.
All right, so I don't like awkward silence, so I'll go.
Thanks, Dr. Miller.
Yeah, so we embrace telehealth from a family medicine perspective very, very early on in the pandemic. We were one of the first to get it up and going. And I have to say I'm on the side of love it because I've been taking care of patients who are underserved my entire career. I love that if their car doesn't, their transportation doesn't show up. I had one patient who I could never get his diabetes under control because it was 50-50 if one of his, he would always say, my kinfolk, if one of his kinfolk would come and pick him up. And so during the pandemic, I got his A1C under control because I told him, we had time for it. And then after, when we could see him back in person, if kinfolk didn't come, I told him just quickly call and say I need it switched to telehealth. Nice. So I love the versatility of it. And so ours is like the COPE program on my OB mat, where it's expected that it's most likely going to be in that group med environment, and it's going to be via their Zoom link. But if there's an issue, we do allow for them to come in for an appointment. Or sometimes there is something that's been big that's happened, like a custody issue that didn't go our patient's way, and they're just not feeling, group that week. And so we do allow an option to convert to brick and mortar. And I have in our policy as services allow, so that we don't, but so far it's worked incredibly well for us. And I do the men's group, and I have a lot of them who work at a local lumberyard. And so they're allowed to do their group therapy and then their medical appointment. So they'll all individually be in their trucks. And I know they're in West Virginia because I actually, you can see the lumberyard. And so it's allowing them to work. And I think that's
I love that. Yeah.
For normality. So yes, I am I am so pro telehealth services.
Yeah.
Yeah. And
Ah.
yes, when someone calls and tells me they have pneumonia on my family med side, I think, you know what, we really need to listen to your lungs. But
Mhm. Sure.
when, yes, but on the side of behavioral health,
Yeah.
like there's
Yeah.
very few times where I don't appreciate it more than not.
Yeah. Oh, Dr. Miller, thank you for pointing out that, yeah, the versatility of it, and being able to offer different things for different patient needs. I love that. It's a great reminder. Thanks for that. Dr. Gorby said, I appreciate your remarks regarding justice and autonomy. That we do a good bit. It allows us to get patients in faster. Ooh, another great point, another great selling point of teletherapy. Very helpful postpartum in patients with multiple comorbidities. Oh, Dr. Gorby, thank you for pointing that out. Yes, our patients that have little tiny kiddos, trying to get them to be able to come in person and trying to navigate either bringing those kiddos into an in-person visit or navigating childcare for that can be a nightmare for folks, but they can still have some, you can leave your little kiddo in the other room while you come into this room and have your therapy session. Or when I have a patient who has a 6-month-old and we're in group therapy, nobody in that group therapy session cares there's a 6-month-old in the room. They're not worried about their confidentiality. So such a great point about, yeah, that's an underserved population that this gets to meet. Thank you for that. Anybody else?
Sarah had commented and said, I
Oh,
love
sorry,
that
I
it
missed
provides
yours.
oh, you're fine. I love that it provides an opportunity for clients to practice coping skills in their home environment.
Yes, Sarah. Yes, that's such a great, right? Like being it for them to be in their home environment where you can role play things while they're in that space or while they have that people around, is priceless. And sometimes that gets, yeah, there's a little bit of lag there when they're coming in person. I love that. Oh, Karen, boy, we have to honor this comment. As we speak, many of our clients are not willing to go out due to their immigration status. Yes, let's talk about we just talked about there's a difference between safety in terms of are they in a safe space like a moving car, and there's also are they safe to leave their home because of what could potentially happen to them. And so being able to provide them medical care while they get to stay in their safe space is priceless. I'm so glad you mentioned that, Karen. Somebody said something earlier. I can't remember what made me think of this, but I got my education many, many moons ago, and I grew up in the time of addiction treatment where it was like patients they gotta work, they gotta suffer to get to treatment, and that's how they know that's how you're gonna know that they really want it because they're bending over backwards for it. That used to be, I'm not saying that in the best way, but that used to be a little bit of the mentality of like, no, they've gotta show that they're ready for this treatment. They gotta show that they've made the effort to come in. And sometimes that's my concern of what holds people back from telehealth services. I remember hearing somebody say, I don't want them to get away. I don't want to let them get away by being able to access telehealth instead of in person. We're not letting them, it's not about it making it anything easier for them or them working less hard for their treatment. It's just about making it more accessible for them so they can get the benefits of treatment. Anybody else? For those of you that facilitate it, for those of you that don't, maybe have concerns about it, ethical concerns about anything that you want to talk about in this space. Those are all great comments. Oh my gosh. One. I would have sworn it was 4:30. Didn't realize I talked so much. I think I just want to show you. So here are some resources. That SAMHSA guide that I talked about is the end reference here, but there's a couple of other ones on here. There is also some selected evidence for telemedicine for SUD, and then just general references. And I think that's it. Great comments in the section and great comments speaking out. I really appreciate you all with that. And we will keep you up to date as we're learning anything in the legislative world. We'll share that with you all. Always appreciate when you come to the space and ask those questions to the larger group. And I think we mentioned not too many meetings ago that if and when there is an opportunity for advocacy for you all, for us as a group, that will be communicating that and tapping everybody in. Because for all those reasons we mentioned today, this is a service we want this needs to stay around. And it might just be that we've just got some convincing to do from those folks that allow us to keep doing it.